All right, terrific. Thank you so very much, Dr. Sidlowski, for that. A lot of information there for hearing impairment. Great. So next, our next speaker is Dr. Megan Jack, who's one of our neurosurgeons at the Cleveland Clinic who specializes in peripheral nerve surgery. And she's going to talk about surgery and tumors of the peripheral nerve, when, why, and what kind. Thanks a lot, Dr. Jack.
Absolutely. Thank you for the introduction. Hopefully, everybody can hear me. So I guess I should probably give a disclaimer first. As a surgeon, I like to show a lot of pictures, both imaging as well as surgery pictures. So I recognize that can sometimes gross people out, particularly like my sister. So if you're that person, you may want to look away and just listen. But today I'm going to talk about peripheral nerve tumors, both in neurofibromatosis type 1 as well as in neurofibromatosis type 2. And we'll kind of go through those, talk about surgery, and I'm also happy to answer any questions. So I think it's initially important to start out with what is a nerve and what does a nerve actually do? So the anatomy of a nerve is really sort of like a multi-system cable. So if you think about kind of wires, electrical wires that are encompassed together, that is what forms a nerve. So the initial part is the axon, and that's kind of a single wire that carries information out to our bodies. And then as you can see here, I've kind of highlighted something called a fascicle, which is actually where a number of different axons are put together, and a fascicle becomes important when we're talking about nerve surgery. So we'll talk about that a few times today. And then ultimately, a number of fascicles all come together to actually form a nerve itself. And nerves are all over the body, and they typically do three types of things. So the first one that we all think about is strength. So it does motion and movement of our limbs and our legs. The other thing it does is sensations. So the touch of your skin, the temperature on your skin, those sorts of sensations are a nerve does that. And then the third thing it does, which I don't think anybody likes, but it does pain as well. And so we'll talk a lot about pain today too. So then ultimately, what are peripheral nerve tumors? So those are tumors that are growing from the nerves themselves. And there's a whole bunch of different kinds. The most common ones that we'll talk about today are sort of form two types. There's the benign type, which are typically not cancerous. And then there's the malignant type, which are cancerous. And the benign type is made up of schwannomas and neurofibromas, which I know you've heard a lot about today. Schwannomas are typically isolated tumors, or meaning a single tumor that we can see on an image or that we can feel oftentimes in the body. And neurofibromas, actually, there's a number of different kinds. There's the ones that we can see on the skin, the cutaneous types. There's ones that are isolated arising from a nerve. And then there's ones that are more generalized, meaning they kind of encompass more structure. So sometimes they encompass areas of difference of the skin, or they can be encompassing almost all of the nerve, like a plexiform neurofibroma. The malignant type we'll touch on a little bit, but there is a risk for patients who do suffer from NF1. They have about 8 to 13% risk of developing a malignant tumor, typically arising from one of their initially benign tumors that goes on to become cancer in the future. So what are some typical symptoms that I see in my patients that present to me with tumors? So oftentimes they are asymptomatic, meaning that there are no underlying symptoms that, the patient knows that there's a growth there, or maybe they don't. Maybe we just see it on imaging. The other part is that they can be exquisitely painful. And unfortunately, I'm sure some of you have already experienced this. I put two pictures of two different types of tumors up there. One is a really, really large tumor. The other is a very, very small tumor. Interestingly, the large tumor was relatively asymptomatic, didn't have a whole lot of pain, but the small tumor was exquisitely painful. So I think it's important to recognize that there is not necessarily a difference between the size. Very small tumors can cause a lot of pain. The other symptoms that we go on to talk about then are numbness and tingling, typically in the distribution that the nerve is going to. And then ultimately there can be weakness too. And that's oftentimes a more concerning feature that we need to investigate as well. So how do we do that? So what do we do if a patient has a tumor that we're worried about or that they're worried about? So oftentimes we start initially with imaging. So the initial kind of testing that we do is with a magnetic resonance imaging. And so this is the type of picture that you see here. It gives us really good definition of that tumor. It tells us where it's located and how it's oftentimes interacting with the nerve. So you can see kind of in the red arrows, there's a large tumor that's actually sitting in the abdomen. And I've highlighted with the blue arrows as well. That's the normal nerve. So we can tell where the tumor is growing from and sort of how the nerve itself is interacting with it. So that's kind of the initial step when we're talking about tumors. If we have concerns that the tumor may not be benign, then you typically go on to look at it with what's called a positron emission tomography or a PET scan. And this is actually looking at sort of the activity of individual tumors. So you can see the same tumor that we just looked at is now highlighted and it's more purple than kind of the surrounding other tissues. So it's measuring the activity of a tumor. Typically with tumors, they're going to be they're always going to have some higher intensity to the activity. We just worry if it gets too high. I think it's also really important to note that it can be really challenging to determine benign tumors from malignant tumors, even with imaging. So we have to kind of put all of the whole picture together to help be able to figure that out. If we recognize that we're really concerned about a patient and that we're concerned that their tumor may be not the benign kind, at that point in time, we typically recommend them undergoing a biopsy, where basically we take a needle, we're able to stick that into the tumor and get a piece of the tumor so to help us with diagnosis ultimately. Now, for a typical tumor that we're not worried about it being malignant, we oftentimes don't recommend this because there's risks that go along with biopsies. As you can imagine, having a nerve close to that biopsy site, we always are concerned that the nerve could be injured and lead to worse symptoms. So we really only recommend this in specific cases where we feel like that patient needs that. So then ultimately it leads to which tumors need surgery, because ultimately not every tumor does need surgery, right? So I kind of have broken it down into 3 different categories where I recommend surgery for a patient. And these are oftentimes growing tumors. So you can see here kind of 2 examples where there's one tumor on the left-hand side that's a little bit smaller, and about a year later, it's increased in size, which you can see on the right-hand side. So growing tumors, we oftentimes recommend removing them because they are growing and they're changing, and we want to make sure that they don't progress. The other one, which oftentimes patients actually complain most about, are painful tumors. So as we talked about, not all tumors are painful, and if they're not painful, we can oftentimes just watch those. But I usually tell my patients that if there is a tumor that is bothering you, so, anytime you go to put on your seatbelt, if a tumor is getting hit and that's causing you a lot of pain, it's worth investigating taking me out. If it's on right where your belt buckle goes every time you put on your pants and that's painful, it's worth taking a look to see if it's able to be removed. So these are 2 different types of tumors that were painful that we ended up taking out as well. And then the third category is talking about what I would consider concerning tumors. So those types of tumors that we're worried could have the potential to be more aggressive or malignant in this nature. So I've kind of shown 2 different types of tumors. Again, we usually get a PET scan to help us localize that. But obviously, if we're concerned for cancer, at that point in time, we're talking about removing the tumor because we don't want it to get bigger, we don't want it to cause symptoms, and we don't want it to spread anywhere else. So usually for concerning tumors where our team has a concern, we typically recommend taking those out as well. So then ultimately, how do we do surgery? So really the goal for surgery for a benign tumor is to remove the tumor and leave the normal nerve behind so that way we're not causing any deficits. And we'll kind of walk through a case for that. So this is a case of a schwannoma. So initially what we do is go down and I find the normal nerve. And then you can see how in the top left corner where the tumor is interacting with the nerve. Actually, I could probably show. Let me get up a pointer for you so I can just point it out for you. Perfect. All right. So the normal nerve is here and the other part of the nerve is down here. And you can see that there's kind of a significant growth here, which is the actual tumor. So what I'm trying to do then is to get down directly on top of the tumor and separate it out from the normal nerve because I want to leave the normal nerve intact and behind, but I want to be able to remove the tumor. And so by doing that, then I can localize the tumor and I can find the single fascicle. Again, remember that single cable that is going into the tumor and exiting out the tumor as well. I'm able to cut that single fascicle on either side, and then we remove the tumor completely, which is seen down here. And you can see the normal nerve, the rest of the nerve is intact and working appropriately. So that's ultimately the goal of how we take out benign tumors. And so in this instance, it was a schwannoma. We can oftentimes take out neurofibromas or isolated neurofibromas in the same manner. But there are key differences between schwannomas and neurofibromas that do influence our surgery and how I approach that. So you can see here on the left is a schwannoma, where typically for schwannomas, a single fascicle is entering and exiting that tumor. So I've highlighted that for you in the kind of red loops or the red arrows. So it's very, very small. The risk of causing any injury to the nerve surrounding it is pretty low. However, if you look on the right-hand picture, which is a neurofibroma, typically for neurofibromas, more of the normal nerve cables are entering the nerve as in comparison to a schwannoma. And so for these types of tumors, we have to be very careful as we're worried about causing a sensory loss or losing sensation in that part of the skin that tumor or that nerve supplies. And we're also worried about potentially if motor fibers are going through that, leaving a patient with weakness afterwards. And so that's where we have to be very careful during surgery to not have that happen. However, there are certain tumors that are not resectable, and I think you can gather that from the big picture that you see. This is a plexiform neurofibroma where all of the nerve that you see there is involved. There's not a single isolated tumor like we saw in the other pictures. Similarly, what you can see in the smaller picture is that there's a large tumor there, a plexiform neurofibroma as well, that is large and can be very challenging to remove. So in these instances, we have to sort of change our approach to how we approach surgery. So what can we do for patients in this type of situation? So ultimately, initially, what we can look at is doing something called surgical debulking. So that's where we take out a portion of the tumor without risking the normal nerve. Now, it's not removing the entire thing, but oftentimes that can be helpful for pain, for cosmetic reasons, things like that. The other one in the larger picture that you just saw, so that's actually right next to the elbow. And so what can happen is nerves typically run through areas where they run through tunnels. And so if a nerve is larger than normal, there can be pressure on that nerve. And so sometimes just opening up the area that it runs can bring a lot of pain relief too. So we're not addressing the tumor per se, but we can lead to reduced pain by just taking the pressure off of it. And I know I'm sure Dr. Patel and many others today have talked about some of the new medications that are available. So that is a potential option for patients as well to help reduce both the size of tumors that can't be resected, which is amazing for us to have now. Sometimes we do recommend radiation therapy, oftentimes not for benign tumors, but typically more for the cancerous types of tumors. And then I know Dr. Tonka after me is going to talk about pain management for specific type of tumors. And so I won't steal his thunder, but there are plenty of other options we have for pain relief in tumors that are not resectable or that can't have surgery. I just wanted to briefly touch on surgery for malignant peripheral nerve sheath tumors, as it's slightly different than the type of tumors that we were talking about before. This is a little bit more involved. Because this is talking about cancer, we oftentimes have to take out we have to resect the entire nerve, the entire tumor, and then some of the areas surrounding that too, to make sure that we get rid of as much cancer cells as possible. And so really that can leave patients with deficits. And so there are other options that we have as peripheral nerve surgeons that we can do to help get back function if that's the case. So occasionally what we can do is go in and take a nerve that is, we basically harvest from a different part of the body, and we sort of use it as a puzzle piece. We kind of fill in the gap for the nerve that we have to take out. So you can see here kind of the damaged nerve or a tumor in this instance, and we can kind of plug in this other nerve to refill the gap, and hopefully the nerve will continue to grow and get back function. Alternatively, if that's not an option, we oftentimes have options for what we call nerve transfers. And this is where we're stealing one of the working wires. So we're stealing another part of a nerve and we're plugging it into a nerve that doesn't work to get back function that way. So we have some other differences in those types of instances where we're talking about, we know we're going to lose function at the time of surgery to get that back. All right, thank you so much for your time, and I'll stick around and I'm happy to answer any questions in the chat as well.